wave and the tissues that you want to treat, otherwise it doesn't travel. And I go in here, I always go with the highest frequency, and then I start with a low dose, because it's going to cost a bit. This here is, on this one here is about 4 or 5, this 0.01 millijoule. Sometimes I have to go lower, especially the more superficial the tissues are, the more tender they are. So we go in here. So I orientate myself from the joint line. I could do meniscus compression and things like that, and that would probably cause some irritation, but it's a very unspecific test to do that. But you should do them, all these tests as I did. So I go in here. So I start out just medial to the patellar tendon. Anything here? 1, 2. Okay. And out here. 4. Out here. Out here. 3. So I go up to the femoral condyle, any pain up here?
3, 4.
Okay. Then I go down to the tibial plateau.
1, 2.
So I can actually isolate each anatomical area to see which is causing the problem. It doesn't seem like it's the attachment sites of the coronary ligaments lying to the meniscus down here. It's more in the joint space itself, so I'm just going to try and orientate the beam of the shockwave device. So I go in here and orientate it downwards. Anything here?
3, 4.
Okay, I go straight into the meniscus, pain here.
4.
And up here.
4.
So we have some other structures lying there which produce pain, the joint capsule and the synovial lining. And probably the medial collateral ligament, as you saw before when I ultrasound scanned it, we see some ingrowths of these metabolic substances which are causing inflammation. So I will start treating this patient here, and I'm going to turn a little bit up until the patient says it's about 7. How much are we on here? 6. So, and this dose I have here is nearly 0.17 millijoule, which is quite okay. I want to be in between 0.1 and 0.3. So I hold it here until the patient actually feels some kind of relief. You tell me when it goes. So it's a little bit down, the pain. Doesn't yet. And you give a dose between 1,000 to 3,000 shots for the area that you want to treat. And you make sure that you have both hands on the device so you don't slip, so you stay at the same time, the same place. The pain's still the same?
Diminishing.
What are we on now in pain level?
4.
So hold it on for at least 500 shots so I'm sure that we have enough energy to go into the tissues to start pain modulation and repair of the processes again. 3. I mean, just give at least 500 shots. I'm going to move it on a little bit here. Anything here? 6. So I scan the area to start out with, so I know which areas that I want to treat here. And I'm going to stay at these 500 shots until the pain subsides. So I'm both going to pain modulate the patient, and I'm going to start some regeneration in the tissues which are inflamed here. If you ordered an ultrasound scan beforehand, you would know what structures are actually afflicted down there. And if you know that the pain fibers actually in those tissues, you might want to try and target these tissues for your treatment. Reducing. So what?
3.
So I'm just going to give it 200 shots more. How far can you run when you run?
I cannot even walk for 2 bus stops.
Cannot walk for 2 bus stops. That's quite limited daily. Yeah. And I'm going to move it once again. And here. No pain?
No.
I'm going to go up here. 5. That's where I scanned for the most pain just before. I give it about 6.
7.
Hold it here. But it's important that the patient actually experiences some pain right now. Otherwise, we won't get some modulation of the pain. Especially several years that the patient had that pain here. So it's going to be sensitized. We know that. You tell me when it's going to go down.
Reducing.
So I'm just going to do 500 shots and I'm going to move it on here. It's bearable. He's done it.
I need a towel to bite on.
So we're just going to cause some more pain here.
Yes, sir.
If it's too painful, you turn down the doses, of course, so it has to be bearable, yeah? And normal from a numerical rating scale is about 7, which is the top that the patient can actually take. So it's reducing. So it's reducing again, so we're pain modulating once more. Next time the patient comes in, he'll be able to take a larger dose, and the pain will subside faster for each treatment. Just 100 shots more. So we continue. And I'm going to move it more medium again. Any pain here? Maybe two only. So it's a very slight pain pattern there. So I'm just going to treat this area too. So we're up to a total of about 300 shots. And that will take you maybe 6 or 7 minutes. Longer does not take. If I had the linear device, I could treat this here much faster because it's a much bigger area that I treat at the same time. But Jason forgot it today. And now, just a pin now. Maybe one. Okay. Give us a minimum of about 500 shots per each area. So, of course we know that this area, anatomically, when we think about it, I have some papers. We know that with any joint, large joint, where we have a joint capsule and we have chronic irritation of ligamentous tissue, synovial tissue, we'll have inflammation being produced in that joint. So I want to go in here and treat that too with the BioLace here. So this is a quite neat little device, as I told you, quite easy to handle. So so it has a little interface here on the front. So you just go in here and choose joint pain. You choose how many watts on this device here that you want to treat, and you do about 200 seconds is enough, even for a large area. That's it. And I'm just going to increase the wattage here. So between 4 and 6, you can go higher, but you have to move it more than. So we got 6 watts and 210 seconds. Quite easy. You press, and it tells you ready in a little while. And then you don't beam it around, show it around. This red light here is just a low surge light, so it doesn't cause any harm. It doesn't start producing any dangerous laser emission before you actually turn on the footprint. You put down the footprint here again, and you move it slowly around the area. And this goes about 3 centimeters down, this wattage here. So you move it slowly in the whole area that you want to treat. So you have to think about a playing card. It has to be that area that you actually expose. And that's why you'll see a reduction of the inflammation immediately afterwards. Just after 200 to 300 seconds. So you see I'm not using very much muscle energy. And then I always ask the patient if they feel any heat in the skin. If they feel too much heat, you can actually increase the distance, or you can move the probe faster around. No, it's just a machine, you can turn it off. It just tells you if you're blind that it's on. So you can just, I've taken the noise off my device back home.
So you don't need to wear your goggles?
You should use them. But as long as you just aim it at the skin, which doesn't reflect, and you don't look into the beam, but it's, you should use it with the patients. Potentially, if you suddenly fall asleep and you don't take your foot off the foot switch here again, you can actually aim at the eyes, and you don't want to do that.
So you don't focus on one point of the
No,
laser?
with the laser you have to use in a wider area, because it's another, you're emitting quite a lot of energy, so if you don't move it, the skin will start actually hurting. And that's, I don't want to just treat a small area, I want to treat the whole capsule, synovial tissue, which is actually, or the ligaments which might be affected by this chronic inflammation from the old injury. So don't think just a cartilage problem or something like that. That's not producing the pain. It's the surrounding structures. So the shockwave you can treat very specific, the worst pain, and where we need to get some regeneration. With this one here you can actually work also on some pain desensitization, but primarily on getting the tissues to heal up faster and get rid of the edema. And edema in the joint causes pressure in the joint. So less than a minute left. So this treatment here may only take 10 minutes with both devices. And often what I do, I have my ultrasound scanner in there, and I let my patients look at the scan while I do it, and I scan them afterwards, and I have a frozen picture of when we started out, and they can see this swelling afterwards. That's quite, and they can feel it too when they actually, often not with the knee, but it might take several treatments for the knee to actually get enough fluid out before they can have a decrease in function. Knee and hip takes a longer time for the fluid to go out.
Do you still do any adjustment, manual adjustment?
I of course do that, yeah. So this is just localized treatment. So I always do my manual work, muscular work, adjustment work if there's restriction or immobilization. I do that first, and I finish off with this here. Many of these patients have already been to a physiotherapist and a chiropractor and medical doctors. They tried pain therapy, they tried rehab and everything else, but there's a persistent inflammation and pain response in the joint. And you can tackle that with these two devices here for a permanent solution.
Facing surgery?
I wouldn't do surgery. That's the last answer. If this here doesn't help, you have to refer to an orthopedic surgeon. But there's no guarantee it will get better.
So, does the result is better with manual therapy, manipulation?
I'd say, well, we've done studies in our clinic, and for all chronic sports injuries, we have we try conservative treatment, and which we don't refer to the orthopedic surgeon, where there's, we sometimes do that because we know we can't help the patient. But those we take in, we have success rate over 90%. And we treat with a laser and a shockwave. We always do other manual therapy if it's needed. If there's a lot of swelling in the joint, I might go in and do aspiration and give a little corticosteroid, wait 2 or 3 weeks, start up the treatment again. If I have a ruptured tendon or a ruptured ACL, I refer to the surgeon. If it's 90% ruptured, I also refer to the surgeon, because I know then it's not possible for me to actually cause the regeneration that I want to. So we're just going to go up here, and you try and relax your knee. It's still painful here. So there's already less pain in the knee joint right now here. So I'm just going to go in here. How much pain do you have now?
No.
There's no pain, so you get immediate pain relief, and the patient often jumps out straight afterwards, I have no pain. But the pain will come back with a chronic condition. It takes more treatments. It typically a knee with this, I would give one treatment for a week, for 6 weeks. And after 3 to 4 weeks, we'll start rehab because the tissues, we want to get rid of the fluid in the tissues. We want to get rid of the inflammation. And I monitor the movement of the leg, so we can actually have pain-free movement. Just unloaded and slightly loaded, we start rehab.
Do you mind the rehab or you send it to another?
We do it in-house. So we work together with physiotherapists. So sometimes I just do the diagnosis. My physiotherapists, they take over treatment, mobilization. So we try to specialize in each area. I have one physiotherapist who does knee, and the other one specialized in hip from his hospital work and things like that. So so they have a lot of knowledge on each area, how to rehab it. But we always try to examine the whole body. So if you examine the knee, you have to look at the pelvis, the lower back, all the other joints. You have to take into consideration too. But we want to get rid of the pain here. And you could also treat the trigger points here with the laser or the focus shock wave. I will always do that here, and the lateral, the vastus lateralis. And I will always look into the hamstrings too, which are often hypertonic. We have less trigger points in them though. But these two muscles are most likely clinically relevant. Any questions?
Can we start the exercise right after the treatment?
We do, depending on how much inflammation there is, I would only recommend doing isometric exercises, light loading, mobility exercises, stretching and things like that. We don't want to produce the patient's known pain. So what I tell all my patients, don't do any activity which reproduces your pain for the next 3 to 4 weeks. So stay down, when it starts hurting, offload it. We need to get some regeneration in there, we need to get some inflammation out there, we need to get some permanent pain modulation and reduction in there. Then we can start loading it again. Then we're starting at scratch, both pain-wise and we have much less irritation in the joint. So look for active passive motion, try and load them. If it reproduces the no pain, don't. If they can do stretching exercises to a certain degree, if they can do isometric exercises, start out immediately. So we have a regime for each condition where we have some tests and functional tests, so we see how fast we can start rehab. The good thing with these two therapies, both by themselves with the laser for acute injuries, is that we can pain modulate them very fast within weeks. And if they don't have any pain anymore, muscular tone is going to start normalizing. So you don't have to treat the muscles all the time. It will start getting better by itself, and you will increase the joint movement and range of motion. So we can start them earlier and accelerate the rehabilitation much faster without going into some new inflammation and new pain production again. Often when I've done this, after 2 months, I have the patient coming back to me, I re-scan them and I retest them for their pain and for the functional ability. And sometimes I have to do, in very chronic cases, I have to treat them 2 or 3 times more, once a week, to get rid of the rest. But otherwise here, I would like just to have scanned them first, to take an x-ray so I can see like how much osteoarthritis is there in there. Often in my old days when I did orthopedic tests and tested the knee and could only get like the knee into here and into here, into extension, I thought, oh, there's many bony spur formations and things like that. When we start treating with this, 3 months afterwards, they have full motion in the knee. They still have arthritis in the knee, but they have no inflammation and they have full function. So we're treating the pain which is causing the functional instability. It's stable enough, the knee. There's nothing wrong with the stability in it. We have some pain production in there we have to get rid of. Often we can do that conservatively, but we have 10 to 15% of these patients who don't respond to normal conservative treatment, including pain therapy and medication and injectional therapy. Then we have to look elsewhere. I look to this with the chronic ones. All the acute ones I can accelerate with this one here. And you often have acute patients coming in, swelling, ligamentous injury, which is acute. You can't mobilize them, you can't touch them. You can go straight in here and starting pain relief and starting reducing the swelling in the joints and the surrounding tissues. So you can limit the inflammatory response so it doesn't spread into the other painful structures. You can actually get this patient out of pain very much faster, and you can get your function faster in, and you can start rehabilitating the patient much better. So this one here is my choice, acute, definitely. And this one is more the chronic ones, and both together with large areas around the hip and the ankle and the knee, because it's not just one structure, it's many structures which have been involved in the inflammatory process. And if you have an ACL, ligament injury, sports injury, you will always have a medial meniscus injury, you will always have some joint capsule and medial collateral injury too of the ligaments, so you have to treat the whole area. Treat the most painful with this one, and then go in and treat all the inflammatory compensation with this one. Does it make sense? And you can see it's quite idiot-proof to use. Even I can use it in clinic practice very, very fast. And I can actually try and establish what's the problem. When I guided the probe into his subchondral bone in the tibial plateau, there was no pain. When I did it on the tibia, there was no pain. But the overlying tissues, we produce pain in. So it's synovial tissue, it's ligamentous tissue, it's joint capsule, which we know is heavily innervated by nerve endings. Any other questions? A lot of fluid. We use, of course, you have to use your Rice principles, but I use this at the same time.
I'm talking chronic, very swollen.
Chronic? I use this.
But even though it's very swollen,
Yeah.
to the point that there's a maybe fluid bulge and there's like
Yes.
moving.
You have to establish what depth you have to work in, and with this device you can actually work up to 7 centimeters down into the joints. So you can go, even if you have swelling, you can actually put your beam zone of treatment underneath the swelling into the tissues producing the swelling. So if you have the ability to palpate on a swollen joint, you can often press in manually and look. I can press 1 centimeter, 2 centimeters down before I actually compress the bony and ligamentous tissues. And then you just choose the gel pad that actually goes that deep into the tissues. So you're not treating the swelling, you're treating the tissues which are producing the swelling.
For ACL reconstruction, that is a screw over the inside the knee. Is there any contraindication for the shock wave?
No, because shock waves with metal implants, titanium implants, only increase the heat, the temperature with 1 to 2 degrees Celsius. And it has no effect on the metal, it just reflects off it. It cannot penetrate it. So it just reflects off. And if there's any metal implant screws which are actually implanted in the cortex, it will make the cortex grow stronger around the metal implants. So it will actually increase the stability of metal implants. So it's just going to cause more bony growth.
No matter what kind of metal the screw is, right?
Yes.
Okay.
So if you have metal implants, it will just reflect off of that, and it will only increase the temperature. If you give, I think they did test with 6,000 shocks with 0.5 millijoules, and it only increased 1 to 2 degrees Celsius. So the patient couldn't feel it. So there's no contraindication there. And often when you have metal implants, you'll have pain at the subchondral bone around the screws. You'll have, and when you give shockwave there, you reproduce it, and after 3-4 treatments, the pain will be gone, because you treated the pain fibers, they will retract, and you will pain modulate it. So with all kind of painful scar tissue formation after operations, we use the focused shockwave, because you get phantom pain due to these irritated nerve endings, and they don't retract in this scar tissue, they stay in there. We don't know why, but we can actually get them to retract and minimize in size, and we can stop the emission of these nociceptive transmitter substances. Like we know that substance P is like a neurotransmitter, both in chemical ways in between cells, but also at nerve endings. And with all chronic muscular and tendinous and bony lesions, we see an increased level of this substance P. After 1 treatment to 2 treatment, you see normal modulation of that again. You go in and you shock the nerve endings and their cells, so they emit the substance P until there's no more left. You keep on hitting them, and then afterwards it's like you press the switch, so it starts producing the normal amounts of substance P. And it's a very complex pain pathway. We see the spinal cord is also involved in that. So, but that's actually, you get rid of the pain, the phantom pain which is in there. So chronic pain is often due to a wrong neurological response. It shouldn't be there anymore. So it should be there, it should be tender when it's injured, because pain modulates your activity, so it can heal up. If you take a lot of painkillers, then you're going to overload the knee. The body gives you pain for a reason. It tells you, don't load the joint, it's injured, I need time to repair. What do? Take painkillers, take an injection, go out and re-injure it again so it doesn't heal up. And that's where we see this chronic scar formation. So if you give, there's nothing wrong with giving pain medication, but you have to limit the activity of the patient. And even though you tell them, they're not going to do as you say. That's why I'm busy every day in practice. These chronic patients come to me because they haven't listened, and after a while, pain medication doesn't take their pain away again because they're sensitized to their pain.
How about if the pain comes from the posterior knee joint, like the capsule, posterior capsule, still apply or avoid?
Then I treat the capsule.
Still posterior is okay?
Yes. There's a few things that when you use focused shock waves, you have to stay away from large nerves because they cause pain. So if you go into the popliteal space, you'll see like the tibial nerve coming down there. You want to avoid that, and you just do that by angle around it. Or you actually use a gel pad, 2 centimeters or 1 centimeter, which goes underneath the nerve. If you hit the nerve, you'll get dermatomal or peripheral nerve emission. If you know your anatomy, you know you're the wrong place. So you want to communicate with the patient and ask for if that's a no pain. For example, if the sciatic nerve over the buttock, if I treat a muscle up there and I hit the sciatic nerve, it will go straight into their foot as if they had a nerve compression. So I move it away from there, and I just angle the probe differently.
But will that shock cause any damage
No.
to the nerve?
No. No, sir. No. With these doses that we used, as I told you, it produced pain, but it will cause no nerve damage.
So how about accidentally on an artery or device?
Yeah, stay away from large arteries and vessels. We don't know how it's going to react if you have some arterial disease. The literature has never shown a case where it has happened with shockwaves. And with the doses that we use below 0.4, you cannot injure human tissue. We have to go up in 2.0, 3.0 millijoules, and this device cannot produce that high levels. So you cannot cause any damage to tissues. You can regenerate nerve too. Carpal tunnel, if you had a compression of that nerve, it works always with focused shock waves. It takes longer time because it regenerates shorter, but they will start growing up again. And again, with peripheral neuropathies like a carpal tunnel, is it the nerve that is sick? No, it's a swelling in the surrounding synovial linings in the tendon sheaths, which are actually causing compression of the nerve. Because we have a limited space with the carpal ligament, the extra buildup of fluid will press and compress the nerve. So we have to get rid of the fluid, the inflammation, by offloading it with these two devices here. Then you don't have to operate. It's totally stupid that you operate.
Even if the
Yeah, you can sit. Thank you very much for your help, sir. Let's give him a hand here. Thank you. So, yes?
Can you talk a bit more about bone bruise or the fracture without displacement?
Yeah, well, I can show you this when we go into the hip. I can actually tell you a little about it, because what we see in hip osteoarthritis, what is it? It's not osteoarthritis causing the pain. When we do MRIs, we always look very much at swelling in the joint, we looked at the cartilage, but when we have cartilage damage in the hip and the knee, you will always have subchondral bone bleeding. You will actually have bone bruises in the bone marrow. You see that in MRIs. And all studies which have been done with focused shock wave on bone bruises show that they disappear, they heal up. And that's where the pain is. It's not from the missing cartilage, it's from the subcortical bone.
So even at a fracture, we can use this?
At fractures, you have a 100% success rate in getting to healing it. We, of course, use conservative measures if they are plastered or booted with plaster for 6 to 8 weeks. we do that as first-line treatment. But if they don't heal up, then you use shockwaves instead of operating. With this new equipment, we can go in and heal up all large, let's say, injuries. I have many marathon runners which have stress fractures of the inferior ramus of the pubic bone. 2 treatments and they heal up within 3 months. Yeah. After 1 week, I see massive callus formation around this chronic fracture site. I just had a 20-year-old girl who ran for a year ago, no, 2 years ago. She trained herself up to a marathon, and she had a fracture, stress fracture, and it didn't want to heal up after 2 years. She had 2 treatments, and after 6 months, she's training up to a new marathon. The ramus is fully normal again. The cortex is normal again.
Do you have any case of like a tear on the Achilles tendon or tear of any tendon?
Any tear of a tendon, as long as there's tendon that actually can reach each other, it will heal up. If you have a partial rupture, if it's more than 50%,
More than
50%, you should refer to the orthopedic surgeon. Because you have to look at the integrity. So you have to do an MRI and ultrasound scan to see how is this tendon looking. Can it regenerate or can it not? I can often treat a patient with that big a rupture, but I have to immobilize them and they are not allowed to run on it, and then it will heal up fine.
The MRI only says longitudinal tear. It didn't say how much of the Achilles tendon was ruptured.
Yeah, so when you treat tendons, if you want to evaluate them, you always do high resolution ultrasound. MRI scan will not tell you very much, only if it's totally ruptured. So you have to do a functional test, you have to move the tendon and joint and see how much tendon has integrity. So refer to a radiologist who does that. I always do that with my tendons.
Did you say for reconstruction of the ACL,
yeah,
only 10% strength compared to the original one, right?
Yeah.
If they do surgery.
Only 10% strength of an ACL for surgery. Yeah. So it's better if you can, leave the ligament in there instead of operating on it.
We didn't really talk much about the contraindications in the mind. The contraindications
For what?
with regards to the shockwave.
With shockwave?
There's the heart
Yeah.
disease. Or
There's only a few contraindications. We don't use it over internal organs, brain, spinal tissue, large nerves and large vessels. Stay away from that. And most sports injuries, you're far away from that tissue. So you're not going to treat the brain or the eyes or anything like that. So you only treat the muscular tendinous tissue here. So,
No, but what about the paraspinal tissues? You say not on the spine.
yeah, with this device you can target the paraspinal muscles and the facet joints and treat that. And without treating I treat many chronic spinal patients who've been operated, or disc prolapse patients who had pain for many years. You can treat them very effectively with this device because it's so easy to modulate here. I scan them always so I can see how far down are the tissues, where are the nerves, and where's the spinal canal, and then you can treat them very, very easily.
Excuse me. Sometimes patients have pain in the inguinal ligament, like
Yeah.
here. Is there any contraindication because it's really close to the femoral artery?
Yeah, stay away from large vessels. And again, let me go into this here, because I'm going to show you how you can treat the hip without hitting these structures here again, all structures. So, can you hear me without the microphone?
Yeah.
Because it gives a straight noise. So let me just go into the other things here again. Oops. Let's first just talk about the foot, and I'll go into the hip afterwards. If that's okay with you. We'll have time for everything. So, the most injured tendon, sports injury tendon, is the Achilles tendon. It's responsible for 70% of all tendon injuries. So you'll see a lot of problems down there. Again, do your examination due to the nose. I'm not going to tell you about that. Always test the stability, ligamental stability of the joint. If you have to refer for radiology or for the orthopedic